Hey everyone, welcome to the show. Today we're talking about high blood pressure, something nearly half of all American adults are living with. Most people, you know the drill. Take the medication, watch your salt, exercise more. But what happens when you do all of that and your blood pressure still will not budge? It just remains exorbitantly high. For millions of people, that's not a hypothetical. That's the reality. And it turns out there's a procedure, FDA approved, Medicare covered, that most patients and even many physicians don't know exists yet. It's called renal denervation. And today we are going to talk about what it is, why it took so long to get here, and what you need to know if you or someone you love has been told their blood pressure is uncontrollable. I'm joined today by two people who have been deep in this work at Medtronic, located right here in the San Francisco Bay Area. Julie Trudell, Senior Director of R&D, and Jason Fontana, VP of Global Marketing and Renal Denervation General Manager. So we're going to get to them in just a moment, but we got to get to Dr. John Phillips first. This is
Hey,
something that's
Kym.
near and dear to you, right? This is something that you brought to my attention and said, Kim, we got to
Yeah.
talk about this.
No, I did, and happy Saturday, and Jason and Julia, thanks for joining us. It's important for a number of reasons, because the procedure itself can be a little bit, I guess, kind of scary when you describe it to a patient. Although when we talk about how this procedure came about, the evolution of it was a large surgery, basically. But when you tell a patient that you're going to put a catheter in their artery and then turn on some heat, basically, and not damage the artery but knock out the nerves, that's a little bit crazy, and it kind of it's part of what we want to do here is demystify some of the things that we do and educate folks.
Yeah, I think people are already getting scared. Heat,
No, 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 no,
catheters.
no, no. This is great. This is going to be great.
Wait a minute.
But the other thing too that's really exciting is that we've known about this type of way to treat hypertension or help, reduce blood pressures for folks has been around for a while. But I mean, it's gone through some ups and downs, and Julie and Jason are going to share the perseverance that they demonstrated to kind of get this thing to market and FDA approval. I think in 2023 or so. So yeah, this is going to be a great show. I'm really excited to talk about it and demystify something.
Is this
Which
something that you've done? Have you done one of these?
yeah. We've
Oh,
done. So there's a clinical trial that we participated in, and then now that it's kind of approved and covered by insurance and in a specific patient population, which we'll dive into because a lot of folks might say, hey, let me have this done. But when you talk about almost half of Americans, adults with high blood pressure or pre-hypertension, and then the fact that very few of them are controlled appropriately. And like hypertension, not to get on a soapbox, but it's often like a pass the buck kind of treatment where, I'm a cardiologist, I'll see a patient and like, oh, your blood pressure was up a little bit today. And oh, well, keep taking your meds. You should probably talk to your primary care doctor. And then it's like, well, the primary care doctor's like, well, the cardiologist didn't fix it. So, well, okay, it's probably okay. And then maybe a kidney doctor will help out and stuff. So again, I think it's also important to learn from the folks at Medtronic who've kind of developed not only obviously the technology, but also like the programming around having a hypertension clinic. And we've done a show on this already, but hopefully today we'll kind of get into the process that it took to get from cutting people open, taking their nerves out to having a catheter ablate, and we'll talk about what that is and help lower people's blood pressure. So pretty excited.
like you're making it sounds like the more you're talking about taking out nerves and this and that, everyone's going, okay, whoa, wait a minute.
Hey,
So
we're here.
we gotta get into this really quickly. So let's start with your moment of inspiration.
Dr. John Phillips, spectacular vascular moment of inspiration.
So I was trying to find an interesting quote from one of the pioneering surgeons of the treatment for people with severe hypertension, like back in the 30s and 40s, was they would take the nerves out, like a surgical procedure, which that's a big deal, which obviously we're not doing anymore because blood pressure meds came about. But I think, and Julie and Jason are going to get into this. This is kind of how the thought process is of knocking the nerves out. So it wasn't a very good quote from one of the surgeons. But so then I said, all right, let me find something from an athlete who just really quick about perseverance, because these guys never gave up with this technology. And this is a simple one from Babe Ruth. And he's quoted as saying, "It's hard to beat a person who never gives up." So there you have it. Never give up, folks.
I love that. I think that really is the name of the game when it comes to this procedure. And I'd love to hear, just introduce so everyone knows. I think Julie has popped in just for a couple seconds. Hi, Julie. Nice to see you.
Hi, nice to invite me. Thank you.
And I want to say hello to Jason as well, so everyone knows his voice. Hi, Jason.
Hi, Kym and Dr. John. Thanks for having us, everybody. Appreciate it.
So I'm curious, have each of you been at the forefront with this, like with this every step of the way? From how long ago did Medtronic start in this journey?
I'll let Julie start, because she may have been the first person to actually look at the first catheter when we looked to acquire this technology. So,
oh, you're kidding.
Well, yeah. So talking about perseverance, I've been involved with this technology since the summer of 2009.
Oh my goodness.
So not many people have the privilege to go through the development of a product and see it through clinical trials and the different ups and downs that we've gone through that we'll discuss today. But yeah, it's been a long time for me.
I've probably been involved from right around 2012 myself at Medtronic, in and around this technology.
So why are you both so passionate about this particular technology? And maybe start with Julie, because you have hunkered down and you have persevered through a lot of bumps along the way that we're going to get into throughout the show.
Okay, I would say at different moment, there's been different reason for why I've been so passionate about it. But at the very beginning, it started by the technology. So I'm an engineer. So of course, the aspect of treating a blood pressure problem with a technology, non-invasive, that was fascinating. And initially it was really a connection with, oh, wow, we could do some meaningful benefit for a patient with a little catheter procedure. Then I would say over time, it became more around the connection with the story that we hear from patients. So yeah, my motivation over the years has been initially on the technology side, evolving to hearing the benefit that some patients would be describing to us. So that's my story here.
And Jason, you have 15 seconds. She left you before break. What about you? Why are you so passionate? Quick.
I'm passionate about it because I got my start at Medtronic thinking about the heart being at the end when somebody's having a heart attack, and being able to go upstream and prevent heart attacks was just a super exciting opportunity to be part of. My 15-second clip there.
Fantastic. We're going to hear more from Jason and Julie coming up next right here on the Heart of Innovation, along with Dr. John Phillips. I want to hear about that patient that made him so passionate about renal denervation and sharing it with you. So stay with us. Don't go away.
How many procedures are you willing to go through? Is it worth going through that many, or would you rather just...
That's funny. Was it worth it? Oh yeah, I have my leg, man.
Amputation should absolutely, positively, 100% never be a first-line treatment.
What an incredible operation, what an incredible lab you have here.
Without a doubt, we're underdiagnosing peripheral arterial disease. It has not gotten the attention that it should, because it is a killing disease, it is a disabling disease, and most importantly, it's a disease that we now have great treatments for.
Okay, let's go to the next one.
They were going to amputate it, and I needed to consult with my family. Did I want it off here or here? You're just shocked. It's scary. I don't even know how to explain it. You're 42 years old.
We're waiting till people are at the end of the spectrum and almost beyond hope. There is good care available here. Closed minds are what we have to get rid of.
Welcome back, everybody. Thanks for joining us. Our show is so relaxed and just kind of free-flowing that my blood pressure right now, I know, is less than 130. It's probably in the 120s, which is where we want it to be. So again, we're talking about hypertension here today, and we're specifically talking about renal artery denervation. Let's take a step back, Julie, if we can. So, and I alluded to this in the beginning of the show, where the people realize that the sympathetic nervous system controlled blood pressure to some degree. And back in the 30s and 40s and 50s and 60s, people were having surgery to remove those nerves. And over time, obviously, it's evolved to what we see now with this catheter. So can you kind of walk us through like what they were thinking about in with respect to the surgery, how the kidneys are involved in this, and then how you ultimately came up with a catheter that is safe to use in a kidney artery that actually lowers blood pressure for folks that have what we call resistant hypertension?
Perfect. I'll go at high level. Most often when we discuss this procedure, there's an element of surprise. Wow, the kidney is involved into controlling this blood pressure. And then we start thinking at the amount of salt, the water, the kidney plays a big role into that by releasing different hormone and controlling the two different sets of hormone, renin and angiotensin. But there's also nerves that start from the brain, go down the spine, and innervate different organs in the body, including the kidney. And those sympathetic nerves, like a little mesh of spaghetti that runs around the renal artery, they control the tone of your artery. And they dictate how much resistance to flow that artery that brings the blood to the kidney will present to the body. Back in the 30s, as you're mentioning, there was an approach with the surgical knife to go and open up the patient by the spine and start cutting those nerves. Well, quite often when you do it surgically, these are hard to see, and you may cut more than what you really should be cutting. So although patients had benefit from having the surgical procedure, sometimes there was some problem because too many of these nerves had been affected by the surgical knife. Then flash forward several years later, then catheter technology became available, and navigating the body through the blood vessel became a thing for different procedures. And it is in the mid 2005, 6, 7 that the first thoughts and piece of intellectual properties were put around this concept. So what this is doing, going with a catheter into the renal artery, it's, and I'm going to do a little bit of a nuance here. We're not heating up the nerve directly. Maybe I do a little exercise with you. If you rub your hand very quickly, you feel warmth.
Yeah.
What we're doing with that little catheter, we're bringing energy right against the vessel wall, and that energy makes the tissue around the renal artery kind of vibrate like you did with your hand. And if you vibrate a lot, it will generate heat, but it's going to be a different type of heat than if you just heat up the blood vessel.
Once connected to the Symplicity G3 generator, the Symplicity spiral catheter is inserted through a small incision and then guided to the renal artery via the abdominal aorta. When the Symplicity spiral catheter is positioned at a desired treatment location within the renal artery, the guide wire is retracted to deploy the catheter, which naturally conforms to the patient's anatomy. The helical shape of the deployed Symplicity spiral catheter, along with its spiral electrode pattern, allows for 4-quadrant ablation, which separates ablation zones to preserve vascular function. The natural coil of the spiral catheter allows for consistent apposition to the arterial wall, so that each of the 4 electrodes can efficiently deliver radiofrequency energy.
So by generating all this vibration, the nerves that are around the renal artery ends up warming up a little bit to a point where their activity level gets interrupted. So what we want to do with this procedure is to affect those nerves in a way that those nerves are not going to be so excited all the time and trying to control the kidney in a way that maybe is not helping the patient.
And so when you do this, that was a really good, that was okay. I completely get it and I have a great visual. So you send in this catheter, somehow you shake things up just a little bit, create a little friction in there, it vibrates, heats things up just enough to disturb or interrupt those nerves. And is it only temporary, or is this something that you have clinical evidence that is long term in terms of the results?
Yeah. So that's the beauty, or that's the effort that went behind the scene to develop the technology. How do we vibrate it long enough with the right intensity to make this be not temporary, but have a long-lasting effect? So that's the work that went on for a few years to get this right, to make this happen in a way that the patient will be experiencing a blood pressure drop over time.
Yeah,
go ahead, Jason.
Yeah,
no, I think. Oh, sorry, Dr.
No, Jason, I wanted to get your thoughts on this.
Oh, yeah. So I think as Julie said, one of the things the audience has probably heard the term fight or flight, right? We're kind of sometimes we're like overactivated and we either run away or we want to stand and fight. In a lot of patients with high blood pressure, that sense that everything is amped up. And so as Julie said, these nerves are constantly firing. And what we've been able to figure out is that you make this one spot and this one change and interrupt the signaling in the kidney of the nerves, and that calms down all these nerves throughout the body. So we were able to target this one spot in a permanent way without putting an implant in or leaving anything behind, but then calms these nerves down, which then leads to the blood pressure reduction. So it's been pretty fascinating.
And so at what point did you actually discover this again? And then why did it hit so many road bumps in the early stages?
You want to start, Jason?
Yeah, sure. So we were on a path. One of the things that's really fascinating is we were on this path of seeing results with this technology back in kind of 2012, 2013. And as we moved down a path, we wanted to make sure that we were comparing it appropriately. So there was a sham procedure where you would do basically the same type of thing that you would do with the catheter for renal denervation, but you wouldn't turn it off, right? So it basically gave the same feeling to the patient, but not applying the energy.
Right.
And
Jason, just real quick, if I could explain that to the patients, because we were part of the early Simplicity trial. I mean, you go through everything with respect to putting a tube in the artery, and the patient's sedated. You're doing everything, and then you don't do you get randomized to doing it or not doing it, and that was a tough thing for me to put somebody through, right? Because you're like, gosh. But you had to do it that way, right? In order to validate the procedure.
Exactly, because you're doing a procedure for somebody with blood pressure. You want to make sure, safe, effective, all the things, right? And so that's where we were at this point in time in 2013. And we ended up with a trial where we got a blood pressure drop with the treatment, but we got a similar blood pressure drop without the treatment. And the question was, well, what happened? Why did these patients who didn't get the treatment have a blood pressure drop? And what we learned, there's a variability in patients, and we put those patients in a clinical trial, but we really babysit them, and they take their medications, and you're always calling them and checking on them. Their blood pressure goes down. But we also learned a lot about the technology as well. We learned about how you do the procedure. We learned about making sure that the procedure itself, we took the variability out of the procedure, we took the variability out of the catheter. And we made those adjustments coming out of 2013, which we'll talk about the journey after and kind of the reboot back to where we are today with the patient.
Yeah, that's a great way to end this segment and move into break. We'll be back right here with more on the journey to bringing renal denervation to millions of patients across the nation with uncontrolled high blood pressure. That's next, right here on the Heart of Innovation on KDOW. Don't go away.
Your type of condition is called critical limb ischemia. It's the most advanced form of P.A.D. or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to P.A.D. and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years and my husband had to quit work.
I didn't know what to do at this point because we had had nothing but infections and hospital stays and infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with P.A.D.
And all I heard was, "What are we doing here? Just cut it off." And I pulled the curtain back like, "Are you kidding me?"
Do you really want to go through all that?
That's crazy. That's insane. The protocol is to send them to amputation. Always, always, always get multiple opinions.
We do have options.
We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
All right, everybody, we're back. We've talked about the procedure. We've talked about kind of how it came about. Now let's get into the missteps, right, Jason? Obviously you guys did the first trial, the Simplicity trials. They were positive, but not kind of, I think, what we wanted. And then, you get to Simplicity 3, so the third derivation of it. And that was, I think, kind of what I thought was the end of denervation, where, if I remember correctly, there wasn't any difference in blood pressure changes, right? But you guys must have noticed something that was still there and obviously kept moving forward, tweaking the catheter, figuring out how to do the procedure better. And then now we've got it FDA approved. So can you share with us kind of that journey as well?
Yeah. And maybe I'll start with, I believe it was like January 13th, 2014. And
not specific or anything.
Not specific. I don't have that in my head at all, right? No. Very cold day in Minneapolis. And we were in a room with our CEO, Omar Ishraq at the time. And he said, first question, is it safe? Is there any signal that this is not a safe procedure? And we said, it's completely safe. No safety signal at all. This is a very safe procedure. Second, he said, do you think it works? And we said, yes, we do. And this is why. And then the final one was funny. Well, not funny at the time, but funny now looking back. And he goes, this is why we do research. We do research and we look at these products to make sure that we're doing the right thing for our patients. So we knew it was safe, and now we have to figure out what were we missing in this trial. And we really boiled down to a couple of things. There was variability in the device, and back then we had a what would be called a single point ablation device. So you'd have to point, move, point. It was very manual, the device, and that led to variability.
Painful,
right?
Yes, for us as
a lot of manual work there.
Yeah.
The second was we didn't at the time understand if the patients we didn't have kind of an evidence from a blood or urine test that said patients took drugs X, Y, and Z, right? So we weren't sure if they were taking too much medication, too little medication, what the changes were. So we couldn't sense the variability of the patient. And then finally, we looked at our device itself, and Julie was working on a new device that we call Spiral, which added more ablations in a real corkscrew-like way. And so those three things led us on the path of kind of next steps here. And we started generating evidence in the absence of medication, kind of a blank backdrop. Does the device work? And then in the presence of medication. And so all the ability to go forward, allowing us to understand all the aspects of this trial. And one of the really fascinating things at that point in time, and I think this is why this show is so great in terms of talking to patients and educating patients. At that point in time, we were kind of struggling to re-enroll again, right? There was a lot of noise out there from Simplicity 3. So for the first time, we ask patients, are you interested in a new way to treat blood pressure? Would you like to be involved in a clinical trial? And it turns out 80% of the patients that enrolled in our clinical program came via what's known as self-referral, which is the patient was interested, right? And so that let us understand there was an interest from the patient community in something new to treat their blood pressure. So that's kind of how the reboot began from the start began.
And I think that's so important, starting with, the interest of the patient, because, as you saw, for example, with the Susan G. Komen Foundation and breast cancer awareness and the push to get mammograms, it was starting with the patients to say, you know what, we're tired of just settling. We deserve something more. If something more is available, let's make it happen. And they went to their doctor and said, hey, and it's just what the pharmaceutical industry does every day with their commercials. Why is it that medical devices can't do the same to say, hey, this is an option? Have the discussion with your doctor. And so I imagine that you had a site, you were able to drive patients to the doctors in their area, right, that were participating. And you're not getting involved. You're saying, hey, there's a physician. The physician knows the criteria and the indications for a patient to participate in the trial. They're the ones who are ultimately deciding either way.
Yeah, and I'll just add to that. I mean, because it can be, Julie, right? It's a slippery slope when industry starts kind of encroaching on making recommendations about procedures. But it also dawned on us, at least at Ohio Health, like you all had resources that we didn't really have, or we hadn't kind of mapped that stuff out yet as to how to reach these patients. Because, I mean, we kind of sometimes use the adage, you've got to kiss a lot of frogs to get the prince or princess. So not everybody, right, gets this procedure. At present, it's a fairly specific patient population.
And I would add, when we had the second chance to do a different type of trial, we were very methodical. So the criteria to be part of this trial were very narrow to start with. And hence your comment, how we needed to kiss several frogs to find your prince. But that's how we were able to understand what had gone wrong in HTN-3 and how we can make this successful moving forward.
Was there any moment that you particularly had a doubt in your mind that you're thinking, you know what? I really hope I'm right, but I just have this one fear or doubt in my mind.
I'm very bold here and I'm going to say no, because at that point in 2014-15, we already had patients who had the procedure done in the early days or emailing us and saying, Medtronic, please do something. Other people need to have this procedure available to them. So at that point in time, there was no doubt.
Yeah,
wow.
And I'll say, I think we enrolled 530 something patients in Simplicity Hypertension 3. I think we did something like 600 analyses of that data set. So we knew every angle and everything that kind of went wrong, and we knew how to come back from it. So I'm confident was there.
And coming up next right here on The Heart of the Innovation, we still need to hear from Dr. John Phillips and his experience with renal denervation, as well as find out if you might be a fit and if you should talk to your doctor and how to talk to them. That's next, right here on KDOW. Don't go away. Do your legs hurt when you walk? Do you feel cramping or numbness that makes you stop and rest? This could be more than just getting older. It could be peripheral artery disease, also called P.A.D. P.A.D. happens when arteries in your legs become clogged, limiting blood flow. And when blood can't flow, your health is at risk. P.A.D. affects millions worldwide. If you have diabetes, high blood pressure, high cholesterol, or if you smoke, you are at higher risk. Symptoms may include leg pain when walking, slow healing wounds, or numbness in your feet. Some people don't notice symptoms at all until it's too late. P.A.D. is serious. It can lead to amputation, heart attacks, and strokes. But the good news? P.A.D. can be treated if caught early. Take a step for your health. Talk to your doctor. Ask about a simple P.A.D. screening test. Protect your legs. Protect your life. Every step matters. Walk strong. Live long. Get screened for P.A.D. Your life and your limb could depend on it.
back, everybody. So twice now, Kym has asked me about a patient that we have treated using this device, and we've had quite a few. And I think what's cool about it is, as physicians, we're becoming more comfortable doing the procedures. There's several partners of mine, Joe and Justin, if you're listening, they're kind of doing the lion's share of these and really trying to support the process. And it is a process. I mean, because again, you do the procedure, but you also are seeing patients that have high blood pressure and trying to help them. And not everybody qualifies for the procedure. I can tell you, we've had a couple that have done really well. And their numbers so their systolic readings continue to be lower than what they were, and we've been able to down titrate some of their medications, which is really fascinating, right? Because as we get older, our vessels become more resistant, and the blood pressure goes up, and so it's really exciting. So, putting my Medtronic hat on, like as you guys are looking to, implement this procedure more widespread, who's the ideal candidate? Who's your avatar that you're after? And so patients can kind of understand, like, I might qualify for this, or no, I might maybe not ready.
Yeah, I think what I would say when you think of that avatar, we bring renal denervation, or we bring a simplicity blood pressure procedure to the conversation as an adjunct, meaning that it's a helper, right? So you're first of all, you've done lifestyle management, you've done the right thing there. Second, you're taking your medications and you're on, you may be on 1, 2, 3, 4 medications, and your blood pressure is still high. And you're doing the right thing, but you need a little help. Renal denervation and kind of our procedure is there as that help, right? And what's great about that is, as you said, not everybody might be qualified to get a simplicity blood pressure procedure, but they're going to be getting their hypertension cared for, right? And what we've done is we work with folks, interventional cardiologists like yourself, John. We set up that, make sure that procedure is well trained. But then around that physician, we create a program to get hypertension treatment, because we're really here to make sure folks are getting hypertension treated regardless of if they get the procedure. So making sure they're taking their meds the right way, making sure they're thinking about their lifestyle. If that's not working, then we're here to help. Additionally, the avatar of a patient who's had some type of cardiovascular backdrop, so their risk level is a little higher, or their adverse effects from the drugs is a little higher. That's an area to have a conversation about renal denervation. And for us, that's the most important thing. It's that discussion between the physician and the patient, and really being aligned and working their way through the right things.
Is there any guidance that you give to physicians to say, hey, here's a checklist. We got to really make sure that you've done X, Y, and Z, and may have done a deeper dive. For example, my mom's blood pressure was absolutely out of control, and they gave her medication and more medication and more medication within weeks. Well, it turns out she had an abdominal aneurysm that was just about to dissect. It dissected, and she passed it unexpectedly. And so I'm curious, and those might be rare, fewer and far between. I don't know. But you could imagine that if someone's on all of these medications, that is there some underlying reason we need to unmask as to why this blood pressure continues to be high? It's not controlled by multiple medications, whether through the heart, through the kidneys, or whatever. And is there a fear that doing this procedure might mask some sort of grander underlying problem that is yet to be discovered?
Well, I'll comment on how at least we approach it, because you do have to make sure you've excluded, reasons for high blood pressure. So folks can have a tumor that secretes too many hormones that can cause high blood pressure. People can have narrowing in the kidney arteries that can cause high blood pressure. So, there is a kind of a checklist. But unfortunately, as we age, like the resistance and the compliance in our arteries changes. And the fact that high blood pressure is present in almost half of all adults, one way or another. And then you couple that with the fact that most people aren't controlled. This is an epidemic, and it's that silent killer that leads to problems with the kidneys and their function, and the heart and stroke and et cetera. But you don't know you really have it And so, if nothing else, like you have to thank, or at least I would say you have to appreciate the effort that companies like Medtronic are doing to help raise awareness about hypertension, right? Because so somebody can be the quarterback of their hypertension care and help them get it under control.
That's right. Yeah, we use kind of guideline checklists, Medicare checklists, and really the FDA. We kind of put those together, and our job is to provide those tools to our partners like John and the other physician community to make sure that they're following kind of this recipe of how to best treat patients with hypertension.
I could imagine for you, Dr. John. I mean, for patients, it's a vicious circle, right? You were mentioning in the beginning about a patient with high blood pressure. They go to the cardiologist, they get on medication, but then they're sent back to the primary care, and then the primary care says, "Well, I guess it's okay." But now you, as a cardiologist, actually have something more that you can do. Before, you felt like your hands were tied. Like, what am I going to do? I've done everything, and how frustrating is that? To not have anything else and finally have something.
Yeah, no, like with any new technology, it's kind of exciting, it's shiny, like, hey, let's see what it does, let it spread its wings. But again, it's all about patient selection, it's all about expectations, and it's also about having a team around you. Like, we're very blessed at Ohio Health. I have two of my partners, Dr. Campbell, Dr. Morrison, like doing this. We're starting a hypertension clinic. We have our nurse practitioner, Chelsea Jones, and our other team that are just helping get these patients in. And at the end of the day, if you can raise awareness about it, just like what you do for P.A.D., I think the world is a better place.
And Julie, from your perspective, what resistance are you facing in the clinical world from physicians? When they're like, I got it. We give medications. We don't need this. Is there any resistance out there to deploying the product?
I think people generally want to understand how it works before using it in a patient. So it's not necessarily resistance, but curiosity and interest in understanding how the technology works. And we're always happy to educate and show what evidence we have and what led us to developing this technology.
Well, coming up next, right here on the Heart of Innovation, we're going to help you, the patient, with the questions that you need to ask your doctor to have a productive discussion to see if this is right for you. So stay with us right here on the Heart of Innovation on KDOW. Don't go away.
When your sugar runs high, it's more than a sign. Diabetes creeping in, it's a dangerous line. Pre-diabetes too, don't think it's too light. It can lead to PAD, so start the fight. Sugar's sweet, but the cost is real. High blood sugar makes your arteries feel clogged. Slow flow, it's a ticking time bomb. Catch it early, stay strong, and keep your legs on. Sugar's not so sweet when your leg is in pain. Not controlling sugar is where peripheral artery disease sets in. Got sugar? Get checked. Don't wait too late. Save your legs, save your life. Take control of your fate. Leg pain, cold feet, neuropathy too. These are signs diabetes caught you. High sugar's the link where circulation and pain left untreated. Your leg might end inflamed.
Unfortunately, this segment is only 4 minutes, which is about actually the time it takes to treat one of the kidney arteries with this procedure, because it's pretty quick. But real quick, before we kind of get into how patients can learn about it and see if they're a fit, Julie or Jason, how close was this technology being to die, just being dead?
Would you want to give that one, Julie? You were kind of there.
Well, it had a big impact within Medtronic when this 2014 data release happened. And I can only be so grateful for the general manager. So Jason, Nina, Sean Salmon, who went in front, and then Jason Whiteman, who went in front of our CEO and advocated for it. It was close to being that, but it took champion. And the CEO was very open-minded, as Jason said at the beginning of this interview, saying this is what research is about. Yeah. So it was close to be dead, but we had the right advocates who were capable to say, let's continue and let's define the path forward.
And so what is the path forward beyond where you are right now with renal denervation? Where does this technology go from here?
So I think we're kind of at the what do they say, the end of the beginning, is that the statement that they use, right? Where now we have kind of coverage in a lot of places, and we're now almost 5 years out on a lot of our big data sets. So the data gets better and better, which is fantastic. And so our job right now is physician education, patient education, setting up the right programs, as we talked about, to make sure patients are getting their hypertension treated. And whether that's medication, whether that's lifestyle management, or whether that's renal denervation, that's fantastic. And then where we go from here, as Julie said at the beginning, these nerves are throughout your body, and kind of the spaghetti is in all your different organs. And so we're really interested in what are the additional benefits beyond reducing blood pressure that can renal denervation can help with.
Yeah. So real quick, like with the GLP-1s for lowering hemoglobin A1C, but oh wow, you lost weight. Have you guys found anything that was just like serendipitous, like, oh wow, we didn't expect this in the data that you have?
So what's interesting is we're now undergoing 2 pilot studies looking at the potential effects of blood pressure lowering and potentially helping with A1C. And we're doing that by not only ablating the renal artery, the kidneys, but also in the liver. And so we're now entering that phase of trying to answer that exact question, which is
that would be great for patients to find out about that kind of trial, that kind of research. I think that would be huge, because patients, anything they can do to not take a pill, they're going to jump at that opportunity. So at least for renal denervation, what are the critical questions that patients should ask their doctor to determine if this is something that's right for them?
Yeah, I think the first thing to do is ask your doctor, right? A lot of times we have a very short moment in time when you get your blood pressure taken in the doctor's office. Take it at your house, take it at your home, provide that information to the doctor, provide that information to the PA or the nurse who might be treating you, and have that conversation. My blood pressure's high, I'm doing the right thing, but I think I can do more. And then we can help you along the way to make sure that not only are you helping with your meds, you're exploring new options, but I think it's really having that first conversation and recognizing that blood pressure is something we got to take advantage, take on, and really get after it.
Thank you so much, Jason. Thank you so much, Julie. For more information, I assume that people can go to Medtronic's website to learn more. And you can also go to youtube.com/the @ the way to my heart.